Welcome to the Deep Dive. Today we're plunging into a topic that demands, well, a really deep understanding. Typically, the domain of medical professionals. The complex world of eye injuries.
It really is. The eye is just incredibly intricate, incredibly delicate. And while it's got these remarkable natural defenses,
Yeah.
the lids, the lashes, the strong orbital bones around it, it's still surprisingly vulnerable.
Vulnerable to quite a range, isn't it? Chemicals, heat, radiation, physical force.
Exactly. All sorts of assaults.
So to really get our heads around this, we're doing a proper deep dive, our source. A detailed section from a medical textbook. Think of this as, well, your accelerated path to understanding eye trauma with the kind of depth needed by the clinicians who actually manage these things. Our mission here is to pull out that essential knowledge, the critical mechanisms, the real nuances of diagnosis and treatment. We want you to understand these injuries like the experts do. We're aiming to cover it all, really, for that level of mastery.
Okay. So, where should we start? Maybe chemical injuries. They're often the most immediate and frankly terrifying ocular emergencies.
Good call. And alkalis. They have a particularly nasty reputation, don't they? Things like lime from mortar or, common lab chemicals. What makes them so uniquely destructive?
Right. This is where the chemistry is just crucial. Alkalis, you see, they're lipophilic.
Meaning they like fats.
Exactly. They readily mix with fat, so they rapidly saponify cell membranes. Literally, they turn the tissue into a kind of soapy substance.
Wow.
And it's not just surface damage. This process breaks down the underlying collagen and proteoglycans in the cornea's structural layer, the stroma. And here's the absolutely critical insight. This breakdown allows the alkali to penetrate incredibly fast and incredibly deep. We're talking seconds.
Seconds.
Seconds. And, maybe even more damaging long-term, they cause rapid occlusion blockage of the tiny blood vessels around the limbus.
The limbus. That's the border zone between the clear cornea and the white sclera.
That's the one. A really vital area for corneal health.
So it's not just a surface burn that kind of stops itself. It's a burn that goes deep and actively cuts off the eye's local blood supply.
Precisely. And that kicks off this devastating cascade. You get diminished blood supply to the whole front part of the eye. The cornea quickly loses its clarity. It can actually start to thin and melt.
Melt. Literally.
Literally melt. Corneal melting, you can get cataracts forming behind the iris and painful adhesions forming between the eyelid and the eyeball. That's called symblepharon. Really limits vision and movement.
The text specifically calls out ammonia and sodium hydroxide as being especially vicious here, causing rapid corneal necrosis.
Dead tissue.
They are particularly bad, yes. Penetrate extremely rapidly.
And it mentions something tricky about how it looks right at the start.
Yes, and this is a potential pitfall, a critical point for anyone assessing these injuries immediately. Initially, you see intense redness, swelling of the conjunctiva cammosus. It looks really angry. But the cornea itself, the clear window, might look deceptively okay, maybe just a bit hazy. So the fact that the cornea doesn't look completely white or destroyed right away doesn't mean it's not a severe burn.
Exactly the opposite, potentially. That deceptively clear cornea could be hiding profound, ongoing damage happening deeper inside because of that penetration and that shutdown of the limbal blood vessels.
Okay.
That's why using fluorescein stain is absolutely essential. It's a dye that highlights any breaks in the surface epithelium. It instantly shows you the full extent of the surface damage, just how much of that protective layer is gone.
So fluorescein tells the real story of the surface.
It does. And then, to really gauge the prognosis, to predict the likely outcome, you need to look carefully at two key things. The degree of circumferential limbal ischemia, basically. How much of that vital limbal blood supply around the edge is visibly damaged or shut down?
You can actually see that, like a whitening.
Yes. You look for blanching or lack of vessels in that zone. And the other key factor is the initial corneal clarity or lack thereof. The textbook mentions specific grading systems like the Hughes-Roper-Hall classification, which uses precisely these factors to grade the severity and predict the final visual outcome.
And based on those factors, the prognosis is often not great.
Often guarded, yes, especially if there's significant limbal ischemia. You have to understand, this is frequently the start of a very long, very difficult recovery process, if indeed useful vision can be recovered at all.
What happens in the really severe cases?
Well, you can get Escher formation, like a scab of dead tissue, then that sloughs off. You get uncontrolled growth of granulation tissue, deep corneal ulcers forming. It can progress to total corneal destruction, perforation of the eye itself, and even the eye shrinking down and becoming non-functional phthisis bulby.
And even if it stops short of that absolute worst-case scenario,
You can still end up with blinding outcomes. A dense, opaque scar on the cornea filled with new blood vessels that's called a vascularized leukoma, permanent sight loss. Plus, significant damage to the ocular surface leads to chronic problems like severe dry eye and those debilitating sympathetic adhesions, especially in the lower fornix, the pocket between the lid and the globe. That really restricts eye movement and interferes with the cornea getting proper nutrition from the tears.
all stemming from that initial chemical splash.
And the root cause of many of the chronic problems, like the cornea repeatedly breaking down or getting covered by conjunctival tissue, that goes back to the severe damage to the limbal stem cells.
Those cells right at the edge, in the limbus.
Yes. They're the source of new, healthy corneal surface cells. The ischemia, that lack of blood flow, just wipes them out in severe burns. When they're gone, the conjunctiva, which has its own stem cells, can just grow over the cornea. That's called conjunctivization. It fundamentally changes the surface, makes it non-transparent.
Okay. Given that truly devastating potential, let's talk treatment. What is the absolute #1 priority for alkali burns?
Immediate, copious, irrigation. Wash it out. Now, the text couldn't be clearer on this.
Right, go wait.
Don't wait for anything. You need to dilute and remove that chemical immediately. Normal saline is the ideal fluid, and a really good tip is to use an intravenous infusion line, hook up a bag of saline to get a steady, directed flow across the entire surface, really getting into the fornices, those pockets under the lids.
Makes sense. A constant flow.
But if saline isn't right there, use any clean fluid, tap water, bottled water. Anything is vastly better than delaying irrigation. You have to keep flushing until the pH of the terafilm is back to normal, which you check with pH paper, or for an absolute minimum of 30 minutes if you can't check pH.
Just keep flushing, nonstop.
Relentlessly. And critically, if it was something like lime or cement, which often contains solid particles, you need perseverance. After putting in some local anesthetic drops, you have to meticulously avert the lids, look in all the corners, and physically pick out every single visible particle with fine forceps. Those particles can sit there and keep releasing alkali.
Right, they act like little depots of chemical.
Exactly. So after you've done the crucial irrigation and particle removal, initial medical therapy usually involves an antibiotic ointment or drops to prevent infection, and cycloplegic drops.
Cycloplegics. They dilate the pupil and relax the focusing muscle, right? Why is that helpful here?
It helps manage the pain from ciliary body spasm, which is common with severe inflammation, and it helps prevent the iris from sticking to the lens, which can happen with severe iritis.
Okay, now steroids. They're powerful anti-inflammatories. Are they used?
Yes, they are important. They reduce the intense inflammation and can help prevent the formation of excessive granulation tissue that leads to those sympathetic adhesions. But, and this is a huge but emphasized in the text, you use them topically or systemically only for the first 10 days or so.
Why the strict time limit? That seems counterintuitive.
Because after about 10 days, the balance of risks shifts. Steroids start to significantly impair corneal healing. They can actually inhibit collagen synthesis and, paradoxically, increase the risk of corneal melting, the very thing you're trying desperately to avoid. So they are a vital tool, but only in that specific early window.
Okay, that's a really critical point for managing these. What about other complications that often crop up? High pressure.
Yeah, intraocular pressure often spikes. For that, you'd use drugs like acetazolamide to reduce aqueous production. To try and support the cornea's structure, ascorbic acid, vitamin C, and tetracyclines, either topically or systemically, can be helpful. They're thought to enhance collagen synthesis and inhibit breakdown.
And specific drops to stop the melting.
Right. There are specific agents used to inhibit collagenolysis, that enzymatic breakdown of corneal collagen that drives melting. Things like 10% sodium citrate drops, 5% acetylcysteine, or sometimes 1% medroxyprogesterone.
And actively working against those adhesions? The sympathetic.
That requires real diligence, regularly, multiple times a day, sweeping the fornices, especially the lower one, with a smooth glass rod coated in lubricant ointment. really getting into that pocket to break up any early adhesions. Packing the fornices with ointment helps too. Sometimes a large diameter specialized contact lens can be used as a physical barrier to keep the raw conjunctival surfaces separated while they heal.
And if the damage is so severe that the surface just can't recover on its own, long-term reconstruction?
If there's extensive limbal stem cell deficiency, yes, you're looking at more advanced surgical options. Things like transplanting limbal stem cells from the patient's other eye or a donor, or using an amniotic membrane graft. These aim to try and re-establish a healthy source of epithelial cells, encourage new blood vessel growth where needed, and promote healing of the corneal surface. It's complex, challenging surgery.
Okay, let's contrast that with acids. Still chemical burns, obviously dangerous, but they work differently.
They do. Acids, like hydrochloric or sulfuric acid, their primary mechanism is to denature and precipitate proteins.
Like cooking an egg white. They make the proteins clump together.
That's a good analogy. They cause the surface proteins to coagulate, essentially creating a barrier of damaged tissue on the surface. And this coagulation actually limits their ability to penetrate deeply into the cornea compared to alkalis.
So they're less likely to cause that rapid, deep tissue destruction and the severe limbal ischemia we see with alkalis.
Generally, yes. The damage tends to be more superficial, at least initially, because the acid sort of walls itself off to some extent.
But treatment is still the same first step.
Absolutely. Immediate, copious irrigation. Saline, clean water, whatever you have. Flush, flush, flush. And while the initial penetration might be less deep, you have to remember that severe acid burns can still cause significant limbal ischemia, subsequent symbolferrin formation, and shortening of the fornices during the healing phase. So that same diligent management to prevent adhesions is still required.
Okay, so moving from chemical assaults to physical force, mechanical injuries, the text gives us a classification system to start.
Yes. It's based on the work of the Ocular Trauma Classification Group, and it provides a really fundamental starting point. It divides injuries based simply on the integrity of the corneoscleral coat. That's the tough outer shell of the eye, the cornea, and sclera.
So the basic question is there a full thickness hole in the outer wall or not?
Exactly. It's that simple at the top level. Open globe means yes, there's a full thickness defect. Closed globe means no, the outer coat is intact, even if there's significant injury inside.
And that these can happen together.
They can occur alone or in combination. The text references a flowchart, 28.1, that lays out the possibilities. And then injuries are further classified by the specific zone involved anterior, posterior, and graded based on initial visual acuity and whether there's an afferentopupillary defect or APD.
And APD tells you about optic nerve function, right?
Correct. It's a quick, early indicator of potentially severe damage affecting the visual pathway.
And with an open globe, there are different types. Ruptures versus lacerations.
Right. Ruptures are typically caused by blunt trauma. The pressure inside the eye spikes and the wall bursts from the inside out, usually at a structurally weak point. Lacerations are caused by sharp objects cutting into the eye from the outside in.
And then penetrating versus perforating.
Penetrating means there's an entry wound, but no exit wound. The object went in and stayed in, or maybe just nicked the surface. Perforating means there's both an entry and an exit wound the object passed right through. Think of a small missile, sometimes called a double perforation.
And closed globe injuries, typically from blunt force.
Usually, yes, resulting in contusions or concussions, bruising or shaking injuries to the internal structures. There's also a category called lamellar laceration, which is a partial thickness cut, not going all the way through the cornea or sclera.
Okay, let's tackle something really common first.
Yeah.
Superficial foreign bodies. Little bits of grit, metal dust.
Yeah, happens all the time. Usually landing on the conjunctiva, the membrane covering the white part and lining the lids, or directly onto the cornea.
What happens if it lands on the conjunctiva?
You get that sudden gritty feeling, discomfort, reflex tearing and blinking. Sometimes the foreign body sticks to the inside surface of the upper eyelid, the palpebral conjunctiva, and then it scratches the cornea with every single blink.
Ouch. Yeah, that sounds intensely irritating.
It is. Or it might get washed away by tears. Or it can lodge in places like the upper tarsal sulcus that groove under the upper lid edge. That's a really common hiding spot causing persistent irritation. Or it might go into the upper fornix, that deep pocket, or even embed itself in the bulbar conjunctiva over the white of the eye.
Can a larger piece just stay stuck up there in the fornix?
Absolutely. The text mentions that scenario. It can be retained, causing chronic irritation, maybe some discharge, and eventually the body might try to wall it off by forming granulation tissue around it. That's why if someone has persistent foreign body sensation but you can't see anything obvious, double averting the upper lid, flipping it twice to really expose that upper fornix is absolutely crucial for diagnosis.
Right, you've got to look in all the nooks and crannies.
You really do.
And corneal foreign bodies, they feel different. Much worse.
Oh yeah. Immense pain, irritation, light sensitivity, watering. Steel or iron particles are very common here, especially from grinding or drilling. They fly off with enough velocity to embed in the epithelium, the surface layer, or sometimes deeper into the stroma, the main substance of the cornea. Larger, sharper ones can even perforate right through. You often see the pupil is constricted to a reflex response.
What's the main danger if you don't get these corneal foreign bodies out promptly?
Infection. Simple as that. Organisms that normally live on the conjunctiva or lid margins can get dragged in with the foreign body, or they can colonize the wound defect afterwards. This can lead to a corneal ulcer.
A microbial keratitis.
Exactly. And that ulcer can spread, potentially leading to a hypopyon. That's when you see a layer of pus, white blood cells, settling in the bottom of the anterior chamber. A very serious sign. The text specifically notes that foreign bodies made of stone seem to carry a higher risk of infection than hot metallic particles, which might be somewhat sterilized by the heat of their creation.
Diagnosing them on the cornea sounds like it needs a good look.
It does. A tiny speck can be surprisingly hard to spot without magnification. Again, fluorescein stain is key. It pools around the foreign body and highlights the epithelial defect. But for really accurate localization, figuring out how deep it is, you need a slit lamp examination. Using oblique illumination, you can often see the particle itself and sometimes estimate its depth by the length of the shadow it casts within the corneal tissue.
How do you actually get them out?
As soon as possible is the rule. Loose ones just sitting in the lower fornix can often be wiped out gently with a sterile cotton swab. For anything stuck under the lid, you need to avert the lid's single or double aversion, and then you can usually flick it off with a swab or needle tip. Embedded ones on the bulbar conjunctiva might need careful removal with a dedicated instrument called a spud, fine forceps, or maybe the tip of the sterile hypodermic needle, always after putting in topical anesthetic.
And those really painful ones stuck on the cornea.
That requires more care. Good magnification is essential, usually at the slit lamp or under an operating microscope. Topical anesthetic drops are crucial to numb the eye. You need to study the patient's head and the globe itself. The first attempt is usually with a sterile foreign body spud, trying to gently lift or scoop the particle out.
And if that doesn't work?
Then you might carefully use the beveled edge of a sterile, disposable hypodermic needle. The absolute key is to minimize trauma to the surrounding healthy epithelium. If it was a steel or iron particle, it often leaves behind a rest ring due to oxidation. If possible, without causing too much collateral damage, you try to gently scrape that rest ring away too, as it can cause persistent inflammation.
What's the aftercare once it's out?
Typically, you'd put in some antibiotic ointment and maybe apply a bandage contact lens or a pressure patch for about 24 hours. This helps the epithelium heal over the defect quickly and comfortably. If an ulcer develops despite this, then you treat it aggressively as a microbial keratitis. And again, remember that higher infection risk associated with stone FBs.
What about particles that go deeper into the cornea, but don't actually perforate into the eye?
Yeah, sharp fragments, like steel, can penetrate quite deep into the stroma. Trying to remove these can sometimes be tricky, as you risk pushing them even deeper, or potentially right through into the anterior chamber. If the particle is magnetic, using a specialized magnet might help lift it out. Otherwise, sometimes a surgeon might need to make a very controlled, partial thickness incision over the foreign body to access and remove it. If it does get inadvertently pushed into the anterior chamber, then it becomes an intraocular foreign body requiring a different surgical approach. And there's one point the text really hammers home about all these superficial foreign bodies.
Let me guess. Prevention.
Absolutely. Prophylactic measures. It's overwhelmingly important, especially in industrial settings, grinding, using a lathe, hammering metal. So many of these injuries are entirely preventable with proper eye protection.
Goggles, face shields.
Exactly. But the text also makes a good point about education and ensuring the provided goggles are actually comfortable and practical to wear. If they're uncomfortable or fog up easily, compliance drops. Prevention is key.
Okay, let's move into the territory of closed globe injuries, the result of blunt trauma, concussion type injuries.
Right. These can cause damage right at the point of impact that's called coup damage. A common example is a corneal abrasion from the object hitting the eye. But perhaps more interestingly, they can also cause damage distant from the impact site due to the shock waves transmitted through the eye. That's contra-coup damage.
Like ripples in a pond, but inside the eye.
Exactly. A classic example of contra-coup is commodio retinae, a bruising or swelling of the retina at the back of the eye, even if the blow was to the front.
And the visual consequences aren't always obvious right away.
That's a critical point.
Oh.
Vision loss from blunt trauma can be significant, but it can also be delayed in onset or even progressive over weeks, months, or years. This really underscores the need for long-term follow-up after any significant blunt eye injury.
What's actually happening mechanically during that blunt impact?
It's complex, but think of it this way. The force hits the cornea, pushing it inwards. This compresses the iris and lens. This pressure creates a wave in the aqueous humor that pushes these structures backwards towards the vitreous. Then, as that compression wave bounces off the back wall of the eye, everything rebounds forward again.
So it's this violent back and forth sloshing.
Yes, this rapid deformation and rebound traumatizes the structures in the front part of the eye. At the same time, there's a sort of horizontal pressure wave that expands outwards, hitting the angle structures where the iris meets the cornea, and also impacting the peripheral retina and choroid. The textbook has a figure, 28.3, that illustrates these incredibly rapid deformations.
It's amazing the eye withstands that at all.
It is, but the consequences can be widespread and appear later. Delayed complications are really common and include things like secondary glaucoma, cataracts, bleeding into the vitreous retinal detachment, or persistent inflammation inside the eye, traumatic iridocyclitis. The text provides a really useful table, table 28.2, that lists all the different structures that can be affected.
Okay, let's use that table as a guide and walk through some of the key structures and the specific damage blunt force can inflict. Starting right at the front, the cornea.
Well, we mentioned abrasions, superficial scratches, or losses of the epithelium. They're easily diagnosed with fluorescein, heal quickly with patching or a bandage lens, usually without scarring. But a common related problem is recurrent erosion syndrome.
Ah, that's where the initial scratch seems to heal okay, but then weeks or months later, the person wakes up, often in the middle of the night, with sudden intense eye pain, like the scratch is reopened.
That's exactly it. It's fundamentally a problem of poor adhesion. The new epithelium that grew over the abrasion hasn't properly anchored itself to the underlying Bowman's membrane, so it just rips off easily, often with the shearing force of opening the eyelids after sleep. Treatment usually involves removing the loose epithelium, maybe roughening the underlying surface slightly, and then using a bandage contact lens and lots of lubricant drops for weeks to allow strong readhesion.
What about deeper corneal effects from blunt trauma?
You can see subtle signs like fine gray lines or striae in the stroma due to temporary swelling or edema, or wrinkling of Descemet's membrane, the very back layer of the cornea. These usually resolve. More significant are actual ruptures or tears in Descemet's membrane. The book shows a picture, Fig 28.4, often associated with trauma during forceps delivery at birth. But it can happen with adult blunt trauma too. These tears cause acute corneal edema as aqueous fluid floods into the stroma, and they can lead to long-term scarring and vision problems.
You also hear about blood staining of the cornea after trauma. How does that happen?
This typically occurs as a complication of a hyphema that's blood collecting in the anterior chamber, the space between the cornea and the iris. It's more likely to happen if intraocular pressure rises significantly due to the hyphema, or if the corneal endothelium, the vital single layer of cells lining the back of the cornea, is damaged by the trauma or the blood products.
What does it look like?
The cornea takes on this diffuse reddish-brown or sometimes greenish discoloration. It clears incredibly slowly, usually starting from the periphery and working inwards, potentially taking months or even years. Even after the visible staining clears, vision can be permanently impaired, probably due to lasting damage to those critical endothelial cells.
Okay, moving outwards to the sclera, the white part. Blunt trauma can actually cause the sclera to rupture.
Yes, this is a globe rupture, technically an open globe injury, but caused by blunt force. It happens when the eye is suddenly and severely compressed, often forced against the bony orbit, maybe from a fall onto something sharp or being hit by a fist or a ball. The internal pressure spikes and the wall gives way at a weak point.
Where does it usually rupture?
Typically either near the limbus, where the cornea meets the sclera, or just behind the points where the eye muscles attach to the globe. These are areas of relative structural weakness.
And sometimes the conjunctiva covering the sclera can stay intact, hiding the rupture underneath.
That's a really important point. You might just see a large subconjunctival hemorrhage, but underneath the sclera is split open. It can mask extensive internal damage like the iris or other uveal tissue prolaxing out, the lens being expelled or dislocated, and often there's massive bleeding inside the eye.
How do you manage a scleral rupture? It sounds like an emergency.
It absolutely is. It requires urgent surgical exploration, usually under general anesthesia, to determine the full extent of the rupture. Any prolapsed uveal tissue needs to be dealt with either very gently reposited back inside if it looks viable, or carefully excised if it's clearly non-viable or contaminated. Then the scleral edges have to be meticulously identified and sutured back together, usually with strong, fine, non-absorbable sutures like 8-0 nylon or polypropylene. Using landmarks like the muscle insertions or the limbus is crucial for proper alignment.
What if the rupture extends way back?
If it extends posteriorly behind the ciliary body region, surgeons often apply gentle cryotherapy freezing treatment around the area of the rupture. This helps create adhesion between the retina and the underlying layers to reduce the risk of a retinal detachment developing later.
And often further surgery is needed down the line.
Frequently, yes, particularly vitreoretinal surgery to deal with associated vitreous hemorrhage, retinal tears, or detachment. The text notes that the optimal timing for this secondary surgery is often around 10 to 14 days after the initial repair. This allows some of the initial inflammation and swelling to settle, and often the posterior vitreous gel starts to separate from the retina, which can make surgery easier.
What about post-op care?
Antibiotics are crucial, of course, and corticosteroids are essential, often continued systemically for several months. This is partly to control inflammation, but also specifically to reduce the risk of sympathetic ophthalmitis developing in the other eye, which is a known, albeit rare, risk after severe penetrating or rupture injuries. In cases where the eye is completely destroyed by the trauma, with no light perception, nucleation removal of the eye might be the only option.
Okay, let's focus on the iris and ciliary body now. Inflammation is common after a blunt hit.
Very common. Post-traumatic iridocyclitis, or uveitis, is almost expected after significant blunt trauma, and it can be quite severe. Interestingly, right after the impact, you might see traumatic miosis, a constricted pupil, due to irritation and spasm. But later you can end up with the opposite, traumatic mydriasis.
That's the pupil that stays large and doesn't react well.
Exactly. Often irregular in shape, poorly reactive to light, and sometimes it's a permanent change due to damage to the iris sphincter muscle or its nerve supply.
Can the iris actually tear?
Small tears right at the pupillary margin are quite common, but usually don't cause significant problems. Much more dramatic is an iridodialysis. The textbook shows this in figure 28.5. This is where the root of the iris, where it attaches to the ciliary body, is torn away from its attachment for part or sometimes all of its circumference.
What does that look like to the observer?
You see a characteristic black, semicircular, or crescent-shaped gap out at the periphery where the iris should be attached. The pupil often becomes D-shaped, pulled away from the area of the tear. If you look with an ophthalmoscope, you can get a red reflex coming back through that peripheral gap, and sometimes you can even see the underlying ciliary processes, zonules, or the edge of the lens through it.
Can that cause visual problems?
If it's large enough to involve the visual axis, it can cause uniocular diplopia, seeing double with just that one eye. It can also cause significant glare and light sensitivity. In very extensive dialyses, the detached segment of iris can sometimes fold forward on itself. That's called anteflexion. Surgical repair is possible by suturing the iris root back to the scleral wall, but it's technically demanding and not always necessary unless the symptoms are very bothersome.
What about total traumatic loss of the iris?
That's called traumatic aniridia, or sometimes iridorrhea. The entire iris is torn off its root attachment. It might contract down into a small ball at the bottom of the anterior chamber, or sometimes it gets pushed posteriorly. It can also be caused by the iris being completely inverted, folded backwards into the ciliary region. A partial inversion might mimic the appearance of a congenital coloboma.
And the ciliary body itself can tear.
Yes. The key injury here is angle recession. Figure 28.6 shows this well. This is typically a tear within the ciliary body itself near its anterior attachment, often separating the circular muscle fibers from the longitudinal ones. When you look at the drainage angle with gonioscopy, you see a characteristic widening of the ciliary body band in the area of the recession. Sometimes you might even see blood in Schlemm's canal right after the injury.
Why is angle recession significant?
Because over time, as that torn ciliary body face retracts posteriorly, it causes scarring and damage to the trabecular meshwork, the eye's main drainage system. This leads to a significantly increased risk of developing secondary open-angle glaucoma, often many months or even years after the initial injury. It's a major long-term complication to watch for after blunt trauma. Histologically, you can see these longitudinal tears in the ciliary body face.
Injury to the iris, or that angle region, seems like a prime cause for bleeding into the eye.
Absolutely. Damage to the blood vessels in the iris, or very commonly associated with angle recession, is the primary cause of hyphema blood in the anterior chamber. Figure 28.7 shows a dramatic example.
What's quite alarming, does it always cause problems?
If it's just a small amount of blood, a microhyphema or a small layered hyphema, it often reabsorbs completely on its own without lasting issues. But a large hyphema, filling a significant portion or all of the anterior chamber, is much more serious. It can clot, and that clot can physically block the pupil or, more importantly, clog up the trabecular meshwork, preventing aqueous fluid from draining out.
Leading to a spike in eye pressure.
Exactly. A secondary glaucoma, which can be very high and difficult to control, potentially causing rapid optic nerve damage.
How do you manage a traumatic hyphema?
Management depends on the size. Small ones might be managed as an outpatient with rest. Larger ones, say filling more than half the chamber, usually warrant hospital admission for close observation. The highest risk period for a secondary bleed, which is often worse than the first, is typically between 72 and 96 hours after the injury. So strict rest, often with the head elevated, is important. Interestingly, the text advises against routine use of atropine, pupil dilator, or steroids in the initial management unless there's significant associated iritis.
What about the high pressure?
That needs to be treated aggressively with topical glaucoma medications or sometimes oral agents like acetazolamide. Drugs that thin the blood, like aspirin or NSAIDs, must be strictly avoided as they increase the risk of rebleeding. If a severe secondary hemorrhage occurs, sometimes intravenous medication like sodium edotate is considered.
Is surgery ever needed?
Yes, if the pressure remains dangerously high despite maximal medical treatment, or if there's a risk of the cornea becoming bloodstained, which happens if high pressure persists with a large hyphema, then surgical evacuation of the clot might be necessary. This is often done using a two-way irrigation aspiration system to wash out the clot while maintaining the anterior chamber. In rare cases of intractable glaucoma, a formal filtering surgery might eventually be needed.
Okay, let's move deeper inside to the lens. Blunt trauma can cause cataracts or dislocation.
Yes, both are significant possibilities. Sometimes, right after the injury, you might see something called a Vossius ring. Figure 28.8 shows one. It's a faint circular ring of pigment deposited on the very front surface of the lens capsule.
Pigment from the iris.
Exactly. It's basically an imprint of the pupillary margin of the iris that was pressed against the lens during the impact. It's a sign that significant force occurred, but the ring itself is usually harmless and fades over time, although sometimes tiny underlying subcapsular opacities remain.
More significantly, you can get a concussion cataract.
Yes. This can take many forms, but the text highlights the classic presentation, the rosette-shaped cataract. This typically forms in the posterior cortex, just under the back capsule, although it can be anterior or involve both. Figure 28.9 shows examples.
What causes that specific rosette shape?
It's thought to be caused partly by the direct mechanical shockwaves disrupting the lens fibers, but perhaps more importantly by tiny, often self-sealing ruptures in the lens capsule, usually at the posterior pole. Aqueous humor leaks in through these micro tears and collects along the natural suture lines and architectural planes of the lens fibers, outlining them and creating those characteristic feathery, petal-like opacities radiating outwards.
Does a concussion cataract always get worse and need surgery?
Not necessarily. If the capsular tear seals quickly, especially if it's small and perhaps covered by the iris, the opacity might remain localized and stationary or even regress slightly. But often the tear remains open, or the damage is more expensive, and the cataract progresses, becoming visually significant. This progression can be rapid, sometimes within hours, or it might take months or even years. A smaller, late rosette can sometimes develop years after the initial trauma.
And treatment, similar to age-related cataracts.
Broadly, yes, the surgical principles outlined in the text's cataract chapter apply. However, a key difference is timing. Surgery for a traumatic cataract is usually delayed for several months, if possible, to allow any associated inflammation in the eye to completely subside and the overall situation to stabilize. Preoperatively, it's vital to assess the integrity of the posterior capsule, often using B-scan ultrasonography, as this influences the surgical plan and the type of intraocular lens, IOL, that can be safely implanted.
Is there ever a time you'd operate sooner?
Yes, the main exception is if the traumatized lens rapidly swells up, becomes intumescent, and pushes the iris forward, causing an acute secondary angle closure glaucoma. That's an emergency requiring prompt lens removal.
Now, lens dislocation. That means the zonules, the fine ligaments holding the lens in place, are torn by the force.
Precisely. The shock wave from the blunt impact can rupture these delicate suspensory ligaments. If only some of the zonules are torn, you get subluxation.
So the lens is loose and shifted, but still partially held.
Correct. It might be displaced sideways or tilted. A key sign is that the depth of the anterior chamber becomes uneven deeper in the area where the zonular support is lost. If you dilate the pupil, you might be able to see the edge of the subluxated lens, sometimes appearing as a black line across the red reflex with an ophthalmoscope. And because the lens isn't held taut anymore, the iris overlying the loosened area often trembles or wobbles with eye movements. That's called iridodenesis. Figure 28.8 actually shows iridodenesis alongside of osseous ring.
And complete dislocation.
That means the zonules are completely ruptured all the way around. The lens is then free to move. Most commonly, it dislocates posteriorly, falling back into the vitreous cavity. Figure 28.11 shows this. It might remain clear for a while or become cataractous. Less commonly, depending on the direction of the blow, it can dislocate anteriorly into the anterior chamber, as seen in figure 28.10.
Anterior dislocation sounds particularly bad.
It is. This can sometimes happen even with relatively slight injury, especially if the lens was already small or somewhat shrunken. A clear lens floating in the anterior chamber can be surprisingly difficult to spot initially, but it won't stay clear. It tends to become more spherical because it's no longer under tension from the zonules. Oblique illumination might reveal a characteristic golden rim due to total internal reflection at its edge.
And the consequences of having a lens loose in the anterior chamber.
It's a disaster. It mechanically irritates the iris and cornea, causing severe sphincter spasm and intense iridocyclitis. It invariably blocks the pupil or the angle, leading to intractable secondary glaucoma. If left untreated, an anteriorly dislocated lens almost always leads to complete loss of vision from the combination of glaucoma and chronic uveitis.
How do these dislocations affect vision?
Subluxation typically causes significant refractive error, often irregular astigmatism, and sometimes myopia due to the change in lens position or tilt. If the edge of the subluxated lens bisects the pupil, it can cause very annoying uniocular diplopia. Complete dislocation into the vitreous leaves the eye aphakic without a lens in the normal position. This results in very high hypermetropia, farsightedness, requiring strong spectacle correction, similar to the vision after the ancient couching procedure for cataracts.
How are dislocated lenses treated?
If the lens is dislocated forward into the anterior chamber, it needs to be removed urgently. This is usually done surgically, often using a cryoprobe to freeze onto the lens, or a special loop called a vectus to scoop it out, combined with an anterior vitrectomy to remove any vitreous gel that prolapses forward during the extraction. If it's dislocated posteriorly into the vitreous, the approach is different. If the eye remains quiet, with no inflammation or glaucoma, you might actually leave it alone. But if it causes uveitis or secondary glaucoma, then it needs to be removed, typically requiring complex posterior segment surgery involving vitrectomy to access and extract the lens from the back of the eye.
Okay, a quick word on the vitreous itself after blunt trauma.
It often becomes disorganized. You can see signs of detachment, either posterior vitreous detachment or sometimes peripheral detachments. Fine pigmentary cells, sometimes appearing as golden brown dots released from the iris or RPE, can be seen floating in it. And vitreous hemorrhage is very common, ranging from mild haze to completely filling the cavity and obscuring any view of the retina.
Deeper still, the choroid, that vascular layer under the retina. What happens there?
Blunt trauma can cause choroidal tears and hemorrhages. The most characteristic injury is a choroidal rupture, shown in figure 28.12. This results from severe blunt contusion forces stretching and tearing the choroid and the overlying retinal pigment epithelium, RPE, and Bruch's membrane.
What does it look like after the initial bleeding clears?
You see one or more characteristic curved, yellowish-white streaks, usually located temporal to the optic disc and running roughly concentric to it. This white streak is actually the underlying sclera visible through the tear in the choroid and RPE. The edges of the rupture tend to become pigmented fairly quickly. Retinal blood vessels usually pass over the rupture undisturbed, which helps distinguish it from a retinal tear.
Does it affect vision?
Significantly, yes. If the rupture passes through or close to the macula, it causes severe and often permanent loss of central vision. Ruptures located further out in the periphery might have less impact on central acuity.
Treatment for a choroidal rupture.
It's mainly conservative. Sometimes systemic steroids are given in the acute phase to try and reduce inflammation and subsequent scarring. A potential late complication to watch for is the development of choroidal neovascularization, abnormal blood vessels growing from the choroid through the rupture site under the retina. This can cause further bleeding or fluid leakage and requires treatment, often with anti-VEGF injections.
And the retina itself seems particularly vulnerable to those shock waves.
It is indeed. You can get retinal edema, degeneration, tears, and hemorrhages. A very common finding after blunt trauma is chemotioretinae, also known somewhat historically as Berlin's edema. This appears as a milky white cloudiness or opacification of the retina, usually at the posterior pole, especially involving the macula. It's caused by photoreceptor outer segment disruption and swelling.
Does vision recover from chemotioretinae?
Often, yes. It can resolve completely over days or weeks with full visual recovery. However, sometimes, especially if severe, it can lead to permanent photoreceptor damage, RPE atrophy, or pigmentary changes in the macula, resulting in chronic central vision loss. The presence of associated intraretinal hemorrhages is generally a sign of more severe retinal damage.
You mentioned traumatic macular degeneration.
Yes, this refers to those chronic changes, often subtle pigmentary alterations developing at the fovea after blunt trauma, which can be progressive and seriously impact central vision over time. Also, severe macular edema can lead to the formation of cystic spaces within the retina. If one of these cysts ruptures, it can create a traumatic macular hole seen as a distinct round or oval reddish defect right at the fovea, causing a significant central scotoma or blind spot.
What about retinal tears from blunt force? Are they common?
Yes, certain types are characteristic. Retinal dialyses are quite common. These are tears right at the ora serrata, the very peripheral edge where the retina transitions to the ciliary body. They typically occur in the supraonasal or inferotemporal quadrants and are thought to be caused by vitreous traction during the rapid deformation of the globe. These dialyses can lead to retinal detachment, sometimes weeks or months after the initial injury. Other types of tears, like horseshoe tears, can also occur due to vitreous traction, though less commonly than dialyses. Very rarely, direct impact can cause a tear.
And in really severe trauma.
In cases like penetrating injuries or gunshot wounds that might cause combined retinal and choroidal rupture, you can get a severe scarring response called traumatic proliferative chorioretinopathy. Fibrous bands form and contract, pulling on the retina, often leading to complex tractional retinal detachments with a guarded prognosis.
Lastly, for closed globe, the optic nerve and intraocular pressure.
The optic nerve can be injured in several ways. Indirectly, often from associated skull-base fractures where bone fragments in the optic canal compress or sever the nerve. Direct penetrating trauma to the nerve is rare. Optic nerve avulsion, where the nerve is literally torn away from the back of the globe, is also rare but devastating, causing immediate blindness. More commonly, you might see hemorrhages within the nerve sheath, or contusion injuries to the nerve fibers, often seen in deceleration injuries like car accidents.
And intraocular pressure. Sounds like it can go either way after a big hit.
It can be seriously disturbed. Sometimes you get hypotony, dangerously low pressure, perhaps due to ciliary body shutdown or a small undetected leak. More often, you worry about traumatic glaucoma high pressure. We already mentioned angle recession as a major cause of insidious late-onset glaucoma due to damage to the outflow channels. Another mechanism is ghost cell glaucoma, where degenerated red blood cells from a vitreous hemorrhage block the trabecular meshwork. These post-traumatic glaucomas can be notoriously difficult to treat, sometimes proving intractable even to multiple medications and surgeries.
Right, let's pivot now. We've covered closed globe extensively. Let's talk about open globe penetrating injuries where something sharp, or a foreign body, actually pierces the eye wall.
Yes, these are always considered potentially blinding emergencies. They require immediate, appropriate first aid and urgent referral for surgical evaluation and repair, typically under general anesthesia.
What makes them so inherently serious?
Several factors. There's the immediate mechanical damage caused by the penetrating object itself. There's the very high likelihood of developing significant post-traumatic iridocyclitis or endophthalmitis, infection inside the eye. There's the risk of introducing infection directly into the eye. And then there's the dreaded, though rare, possibility of sympathetic ophthalmitis developing in the other, uninjured eye later on.
What's the absolute essential initial management? The text calls it open trauma primary therapy.
Key steps. First, protect the eye. Apply a rigid eye shield like a plastic or metal cup taped securely over the eye socket. Critically, do not apply a soft pressure patch, as that can press on the open globe and potentially extrude intraocular contents. Second, systemic antibiotics are crucial, usually given intravenously, broad spectrum, as soon as possible to try and prevent infection. Third, ensure tetanus immunization is up to date, giving a booster if needed. And fourth, critically important, no topical medications, no drops, no ointments should be put into the injured eye before it's assessed surgically, as they could be toxic to intraocular structures or introduce infection. Then, urgent referral to an ophthalmologist.
Okay. Shield, 5 antibiotics, tetanus check, no drops, refer urgently. Got it. Now, looking at specific wounds, conjunctival cuts are common.
Yes, and relatively minor on their own, but they should always be carefully explored to make sure there isn't a hidden scleral laceration underneath, and then sutured, usually with fine absorbable material.
What about wounds to the cornea and sclera themselves?
They can be linear cuts or more ragged lacerations. An interesting point the text makes is that the wound margins often swell and become somewhat cloudy shortly after the injury. This actually helps make the edges more visible for accurate suturing. Small, clean, central corneal wounds tend to heal quite well if they don't get infected. An indected corneal wound, though, looks much like a perforating ulcer, as shown in figure 28.13a, with 28.13b showing a repaired wound.
Larger wounds often have tissue prolapsing out.
Very often, yes, especially if they're not perfectly linear or if there was significant pressure. Iris tissue is the most common thing to prolapse through corneal or limbal wounds. For small, recent injuries where the prolapsed iris looks healthy, the surgeon might attempt to gently reposition it back inside the eye, sometimes using medications like Miochol or pilocarpine instilled into the anterior chamber to constrict the pupil and pull the iris back in. Then the wound is meticulously sutured, typically with very fine 10-0 nylon sutures.
What if the prolapsed iris looks damaged or has been out for a while?
If it appears crushed, devitalized, or potentially contaminated, then it must be carefully abscised cut away at the level of the wound. You never push potentially non-viable or infected tissue back into the eye. After excision, the wound is closed securely, again paying close attention to anatomical landmarks like the limbus to ensure correct alignment. For scleral wounds, particularly those located more than 3 or 4 millimeters behind the limbus, thorough exploration is needed to rule out retained foreign bodies or deeper damage like retinal tears before complete suture closure. Applying cryotherapy around posterior scleral wounds is often done to reduce the risk of later retinal detachment.
Infection is a huge concern with penetrating injuries, isn't it? Especially if the object was dirty.
A massive risk. If the injury was caused by something contaminated, like soil, a dirty tool, or particularly vegetable matter, it can introduce highly virulent pyogenic pus-forming organisms directly into the eye.
What can happen then?
This can lead to devastating consequences very quickly. Rapid corneal necrosis, sometimes forming a characteristic ring abscess, a deep, ominous ring of inflammatory infiltrate just inside the limbus. Certain bacteria, like Pseudomonas aeruginosa, are notorious culprits, causing rapid, extensive conjunctival swelling, chemosis, often with a characteristic greenish discharge, rapid liquefaction and melting of the cornea, and swift progression to panophthalmitis infection involving the entire globe.
How do you even treat that?
It requires immediate and intensive treatment with broad-spectrum systemic, topical, and sometimes intraocular antibiotics. Despite this, the prognosis is often poor, and sometimes an emergency corneal transplant, keratoplasty, is needed just to salvage the globe itself. If infection gets established inside the eye, in the anterior chamber or vitreous, it causes purulent iridocyclitis, hypopyon, and ophthalmitis, and again, can rapidly progress to panophthalmitis, often resulting in complete loss of the eye.
Another major complication of penetration is wounding the lens.
Yes, if the penetrating object passes through the lens, it's a very serious complication, invariably causing a traumatic cataract. Even a tiny puncture of the lens capsule allows aqueous humor to seep in, causing the lens fibers to hydrate and opacify.
Does it look like the concussion cataract we discussed?
Often, yes. You can see localized cloudiness, and those characteristic feathery lines develop in the posterior cortex, sometimes forming a rosette shape, just like in figure 28.9d again. Small capsular wounds might theoretically seal, potentially stopping the progression, but usually the cataract progresses to become completely opaque and visually significant. Before considering surgery, assessing the integrity of the posterior capsule with ultrasound is crucial.
And a badly damaged lens. It swells up.
Yes, the lens can opacify very rapidly, becoming swollen and white. Flocculent, fluffy lens material can extrude through the capsular opening into the anterior or posterior chambers. This swollen, inflamed lens material can itself cause significant secondary complications like severe iridocyclitis, mechanical blockage leading to secondary glaucoma, if it's not removed in a timely manner, often by aspirating the lens material out.
So how are these penetrating traumatic cataracts generally managed surgically?
The approach usually involves several components. Removing the cataractus lens material, often via aspiration or phacoemulsification if possible, performing an adequate vitrectomy, especially if the posterior capsule is breached, to remove any prolapsed vitreous or associated hemorrhage, meticulously suturing the primary globe wound closed, and then, if the eye's condition and posterior capsule status allow, inserting an intraocular lens, IOL, to restore focus.
In managing inflammation and infection is key.
Absolutely paramount. Aggressive control using intraocular, systemic, and topical antibiotics and corticosteroids is essential throughout the process. Despite the best surgical efforts, however, the text sadly notes that many eyes suffering severe penetrating trauma, especially those involving the lens and posterior segment, ultimately become atrophic and non-seeing, a condition called ophthalmitis bulbine.
Are there any particularly nasty or specific infections to worry about with penetrating trauma?
The text mentions two specifically. Gas-forming organisms like Clostridium welki, though rare, cause an incredibly virulent, rapidly progressive panophthalmitis, often with brownish discharge and visible gas bubbles inside the eye. Even with massive doses of penicillin, vision is invariably lost. Tetanus is another rare but potential risk, particularly with injuries contaminated by soil or occurring in agricultural settings or road accidents. It can cause a localized cephalic tetanus affecting cranial nerves. Prophylactic tetanus toxoid is therefore mandatory if the patient's immunization isn't current.
And looking back at the injury, what factors suggest a poor visual outcome is likely, even after good repair?
The text lists several key risk factors for poor visual return. Having a double penetrating or perforating injury, entry and exit wound, the presence of dense vitreous hemorrhage obscuring the view, and, interestingly, if the open globe injury was actually caused by blunt trauma resulting in a rupture rather than a sharp laceration. A rupture implies much greater overall force and associated internal damage.
Okay, now let's add yet another layer of complexity. Open globe penetrating wounds, where a foreign body is actually retained inside the eye.
Right. This significantly increases the risk and the complexity of management compared to a simple penetration.
What kinds of foreign bodies are most common?
By far the most common, accounting for maybe 90% in industrial settings, are minute chips of iron or steel, often from hammering or grinding. But you also see stone fragments, glass, lead pellets, copper wire fragments, wood splinters. The text makes the interesting point that when someone is hammering a chisel in stone, the resulting intraocular foreign body is often actually a tiny chip off the chisel itself, not the stone.
Size and velocity must be critical factors.
Hugely important. A large, high-velocity object obviously causes extensive immediate damage as it enters, but even tiny microscopic particles, if they penetrate the globe, can cause significant problems. Retained foreign bodies cause harm in three main ways. First, the direct mechanical damage as they pass through tissues and lodge somewhere. Second, by introducing infection. And third, through specific chemical or toxic reactions depending on the material the foreign body is made of.
Let's break down the mechanical effects first. Where can these things end up?
Well, if it enters through the cornea, it might stop in the anterior chamber. It could fall down and settle in the inferior angle, where it might only be visible with gonioscopy. The text diagrams its removal from the angle in figure 28.14c, or it could get caught up in the iris tissue, where you might see it directly with a slit lamp. Glass foreign bodies can be particularly tricky to see in the anterior chamber because their refractive index is quite similar to the aqueous humor. Figure 28.14a and b show imaging helping locate a metallic FB in the angle.
It can also go into or right through the lens.
Yes, either passing through the pupil or directly perforating the iris and then the lens. If it goes into or through the lens, it invariably causes a traumatic cataract. And if it passed through the iris tissue on its way, you'll see a telltale hole in the iris.
That iris hole sounds diagnostic.
The text calls it pathognomonic of a foreign body perforation. It appears black by oblique illumination, but shows a red reflex when you illuminate the fundus with an ophthalmoscope, unless the lens behind it has already turned opaque. A foreign body can also, surprisingly, sometimes pass around the lens through the circumlental space between the lens edge and the ciliary body to enter the posterior segment without actually damaging the lens itself.
And if it gets into the vitreous cavity?
This can happen via several routes through cornea, iris, lens, pupil, zonules, or directly through the sclera. Once in the vitreous gel, a small, light foreign body might initially remain suspended. But over time, as the vitreous liquefies around it, it usually sinks down towards the bottom of the eye. If the vitreous and lens are still clear, you might be able to see the foreign body directly with an ophthalmoscope, or sometimes you can see the grayish track it left as it passed through the vitreous, or see where it impacted the retina.
High-energy ones can cause more damage.
Yes, high-energy particles might hit the retina, possibly ricochet off the back wall and come to rest elsewhere, or they might have enough energy to pass right through the back of the eye into the orbit that's a double perforation. Figure 28.15 shows an eye with cytorosis from a retained FB, highlighting the corneal wound, iris damage, and discoloration.
What if it ends up embedded in the retina?
It typically appears as a dark or metallic-looking object, often initially surrounded by some retinal exudate or hemorrhage. Over time, the retina reacts around it, sometimes encapsulating it with fibrous tissue or developing pigmentary changes. Any foreign body lodging in the posterior segment, especially near the macula, carries a significant risk of causing degenerative changes and severe vision loss. Vitreous changes, hemorrhage, and retinal detachment are all common sequelae, and we have to constantly remember the risk of infection with any retained foreign body.
Even more so than with just a clean, penetrating wound.
Definitely. Although it's thought that small metallic particles entering at high speed might sometimes be sterilized by the heat generated, foreign bodies like stone, soil, or particularly wood are much more likely to carry bacteria or fungi into the eye. Prophylactic antibiotics are always given, but despite this, the prognosis for vision if an intraocular infection develops from a retained foreign body is often very poor.
Now, this next part is really fascinating. How the eye tissues react chemically to different types of foreign body materials.
Yes, this is highly variable and critically important for prognosis and management. It depends entirely on the chemical nature of the retained material. Non-organic materials generally fall into different categories based on the type of tissue reaction they provoke.
Some are basically inert, they don't react much.
Correct. Things like glass, many modern plastics like PMMA or silicone, porcelain, and noble metals, gold, silver, platinum, titanium. These generally cause little or no significant chemical reaction within the eye tissues. They might still cause problems mechanically or trigger a low-grade chronic inflammation later, but they don't typically cause toxic degeneration.
What about other metals?
Some metals cause a primarily local irritative reaction, leading the body to try and wall them off with fibrous encapsulation lead as an example. Others are frankly suppurative, meaning they incite a severe pus-forming inflammatory reaction. Zinc, nickel, and mercury fall into this category. And then there are the two most important ones with specific, widespread degenerative actions: iron and copper.
Iron causing cytorosis, Bulby.
Exactly. Steel foreign bodies cause cytorosis in proportion to their iron content. The underlying mechanism is thought to involve electrolytic dissociation of the iron within the eye's fluids. These dissociated iron ions then spread throughout the ocular tissues and bind to intracellular proteins, particularly affecting epithelial cells, leading to widespread cellular damage and eventual atrophy. Different tissues are affected to different extents.
What are the classic clinical signs of cytorosis?
One of the earliest and most characteristic signs considered pathognomonic is the appearance of small rusty brown spots or patches on the anterior lens capsule, often arranged in a ring corresponding to the edge of the normally dilated pupil. This indicates iron deposition and inevitably leads to cataract formation. The iris also becomes stained, initially taking on a greenish hue, then progressing to a diffuse reddish-brown, often resulting in heterochromia iridis, the two irises having different colors. Figure 28.15's caption mentions this iris staining. Iron deposition in the iris sphincter muscle causes it to weaken, leading to a progressively dilated pupil, mydriasis.
And it affects vision.
Profoundly. Vision gradually fails due to a combination of the developing cataract and progressive retinal degeneration. The retinal changes can actually mimic the appearance of retinitis pigmentosa, with pigment clumping and attenuated vessels. The electroretinogram, ERG, which measures retinal electrical responses, shows characteristic changes. Early on, the A wave might increase, but later the B wave diminishes progressively, eventually leading to a flat extinguished ERG in advanced disease. Chronic secondary glaucoma is also a common late complication. If the iron source isn't removed or effectively encapsulated, untreated cyrosis typically leads to blindness.
Can you actually see the iron deposits microscopically?
Yes, using a special stain called the Prussian blue reaction on histological specimens. It stains the iron deposits a characteristic bright blue, revealing their presence in corneal cells, keratocytes, the trabecular meshwork, the ciliary epithelium around retinal blood vessels within the iris stroma, and particularly concentrated in the lens epithelium. The staining is often most intense right around the foreign body itself.
Okay, now copper, that causes chalcosis.
Yes, but the reaction to copper depends heavily on its purity. Pure copper, or alloys with very high copper content, elicit a violent, often sterile inflammatory reaction. This can lead either to dense fibrous tissue formation and encapsulation, or sometimes to a severe suppurative reaction resulting in shrinkage and loss of the eye. Phthisis.
What about alloys like brass?
Alloys with a lower copper content, like brass, which typically has less than 85% copper, tend to cause a milder, more chronic and distinctive reaction called chalcosis. This also involves electrolytic dissociation and deposition of copper ions within the eye.
Where does the copper get deposited in chalcosis?
It tends to deposit preferentially on certain membranes within the eye that seem to resist its further migration. Classic sites include Descemet's membrane at the corneal periphery, where it can form a golden brown ring similar in appearance to the Kaiser-Fleischer ring seen in Wilson's disease. It also deposits under the anterior lens capsule, creating a brilliant metallic, often greenish gold sheen with radiating spokes like the petals of a flower. This is the classic sunflower cataract, shown beautifully in figure 28.16. Copper can also deposit as refractile particles or golden plaques on the surface of the retina, particularly at the posterior pole.
Now, the text mentioned that vision can sometimes remain quite good with chalcosis, which seems different from the progressive destruction of siderosis.
That's a really key distinction. Unlike iron, copper doesn't seem to combine chemically with vital intracellular proteins in the same way. So while the copper deposits are clearly visible and indicate toxicity, they don't cause the same widespread cellular degeneration and atrophy seen in siderosis. If the copper foreign body is removed and the toxicity wasn't overwhelming, vision can sometimes be surprisingly well preserved long term.
And finally, what about organic materials as retain foreign bodies? Wood, plant matter.
They tend to elicit a different type of reaction, again, typically a chronic, proliferative, inflammatory response, often with the formation of granulation tissue. Vegetable matter carries a particularly high risk of introducing fungal infection, which can be very difficult to treat. Wood and other vegetable fragments characteristically provoke a foreign body giant cell reaction as the body tries to engulf and break them down.
Any other odd organic materials?
The text mentions eyelashes being carried into the anterior chamber during trauma. These can sometimes lead to the formation of intraocular cysts due to proliferation of the surface epithelium dragged in with the lash, and caterpillar hairs, though not usually penetrating in the same way if they get onto the ocular surface, can migrate into the eye and cause a severe, specific type of granulomatous iridocyclitis with characteristic nodules, a condition called ophthalmia nodosa.
Okay, diagnosing an intraocular foreign body sounds absolutely critical, especially since the patient might not even know something went in.
It is paramount. A high index of suspicion is needed. A careful history is key, asking specifically about activities like hammering metal on metal, using power tools without protection, or being near an explosion. Then, a meticulous examination is required.
What are you looking for?
You have to search diligently for the wound of entry. It might be a tiny, easily missed corneal scar, sometimes only visible with a slit lamp. Scleral entry wounds can be even harder to find, often hidden under intact conjunctiva or hemorrhage. Then you need a thorough slit lamp exam of the anterior segment, including gonioscopy to visualize the angle structures. Looking for that pathognomonic iris hole or an opaque track through the lens is vital. If the media are clear enough, a dilated fundus examination is essential to search the vitreous cavity and the retinal surface.
But often the view is hazy, or the foreign body is hidden. Imaging is indispensable then.
Absolutely indispensable, especially for detecting radio-opaque foreign bodies, which includes most metallic objects. Standard skull X-rays, typically Caldwell and lateral views, are often the first step. Various localization techniques can be used with X-rays, like placing a radio-opaque limbal ring or a special contact lens on the eye and taking repeat films to pinpoint the foreign body's position relative to these known landmarks.
What about more advanced imaging?
CT scanning is now widely used and is highly accurate for detecting and localizing even very small foreign bodies, metallic or otherwise, like glass or stone. It also shows associated injuries like orbital fractures. MRI is generally contraindicated if a metallic foreign body is suspected due to the risk of the powerful magnetic field moving the object and causing further damage. However, MRI can be very useful for detecting non-metallic foreign bodies like wood, which are often missed on CT or X-ray, and for evaluating associated soft tissue or vascular changes.
And ultrasound.
Ultrasonography B-scan is also an excellent tool. It's non-invasive, readily available, and can detect most types of intraocular foreign bodies, even radiolucent ones. Crucially, it can also simultaneously evaluate associated conditions like vitreous hemorrhage, retinal detachment, or choroidal detachment, even when the view into the eye is obscured by blood or cataract. Figure 28.14 shows an example of ultrasound localization.
So once you've found it, the general rule is to remove it. Are there exceptions?
The general principle is yes, remove it. However, removal is not always undertaken. You might elect to leave a foreign body in place if it's proven to be truly inert, like glass or plastic, appears sterile, caused minimal initial damage upon entry, is located in a position where removal would be extremely hazardous and likely to destroy remaining vision, and the eye is quiet. But these cases are the exception. Most retained foreign bodies, especially metallic or organic ones, need to come out.
How are magnetic ones removed?
If the foreign body is magnetizable, iron or steel, it can often be removed using specialized ophthalmic magnets. Depending on its location, this might be done via an anterior route, through the limbus or cornea, or a posterior route, through the sclera. Small intravitreal magnets can be used for particles floating in the vitreous. If a magnetic FB is embedded in the lens, you might have to treat it as non-magnetic or remove the entire lens with the FB inside. For magnetic FBs in the vitreous or on the retina, the modern approach usually involves posterior segment surgery, vitrectomy, combined with use of an intravitreal magnet or specialized forceps, along with techniques to manage associated fibrous tissue or retinal breaks. Subretinal FBs might require an external approach through the sclera or an internal approach during vitrectomy.
What are the typical outcomes after removal?
Often surprisingly good initially, if the surgery is successful in removing the foreign body without major complications. However, the long-term visual prognosis, especially after posterior segment foreign bodies, must remain guarded. Even after removal, the track left by the foreign body through the vitreous can act as a scaffold for fibrous tissue to grow along. This can contract over time, causing traction on the retina, leading to delayed retinal detachment and vision loss.
Modern surgery helps, though.
Yes, modern vitreoretinal surgical techniques have significantly improved the management of these complex cases. Vitrectomy allows surgeons to clear vitreous hemorrhage and opacities, remove the foreign body under direct visualization using fine instruments, peel away tractional membranes, and treat retinal breaks with laser or cryotherapy. Despite this, post-operative complications like epiretinal membrane formation, macula pucker, or proliferative vitreoretinopathy, PVR, can still occur and severely limit the quality of the final vision. Therefore, prolonged, careful follow-up is absolutely essential after any intraocular foreign body removal.
How about extracting non-magnetic foreign bodies?
Removal from the anterior segment is generally less complex than from the posterior segment. A foreign body caught in the iris might be grasped directly with forceps through a small corneal incision, or sometimes removing a small piece of the iris containing the foreign body, in iridectomy, is necessary. Foreign bodies lodged in the angle often require a specialized surgical approach, sometimes involving making an incision just inside the limbus and using specific non-toothed forceps for extraction, as diagrammed in figure 28.42.
And if it's non-magnetic, in the lens or retina?
A non-magnetic foreign body within the lens is usually removed along with the cataractus lens material itself, typically via aspiration or phacoemulsification, once the aqueous has softened the lens. For non-magnetic FBs on or embedded in the retina, extraction requires advanced vitreoretinal surgery. This involves performing a vitrectomy to gain access, using specialized intraocular forceps to grasp the foreign body, carefully removing it from the eye, and often treating the surrounding retina with laser photocoagulation to prevent tears or detachment at the removal site.
So the overall prognosis really hinges on many factors.
It really does. Even if the initial damage seems minor, a retained intraocular foreign body always carries a serious prognosis. The outcome varies hugely depending on the location of the foreign body, its size and chemical nature, the presence of infection, and the extent of associated damage. Leaving an inert FB might be okay, but even then, chronic iridocyclitis is a risk later. Leaving a non-inert FB almost guarantees a bad outcome. Removal from the anterior chamber generally has a good prognosis if the lens wasn't injured. Lens injury significantly complicates things. And even after successful extraction from the posterior segment, long-term follow-up is crucial because of the high risk of delayed complications like retinal detachment or PVR.
Okay, one last major topic related to penetrating injuries. Sympathetic ophthalmitis. That rare but truly dreaded complication.
Yes, this is a severe bilateral granulomatous inflammation that occurs in the sound previously uninjured eye after a penetrating injury or sometimes surgery to the other eye. Thankfully, it's become much rarer now with modern surgical techniques and steroid use.
What's the typical trigger?
It almost always follows a penetrating wound to the first eye, the exciting eye. Estimates suggest it occurs in perhaps 0.2% to 0.5% of such injuries. The risk seems to be significantly higher if uveal tissue, that's iris, ciliary body, or choroid, or perhaps lens capsule material, becomes incarcerated or trapped within the wound scar during healing. It's much rarer after routine, uncomplicated elective eye surgery, unless there's significant tissue incarceration in the wound. It has also been reported, very rarely, after certain types of laser eye procedures. Interestingly, the text notes it rarely seems to happen if the injured eye became frankly infected and developed endophthalmitis.
When does it typically appear? Is there a time frame?
It seems children might be slightly more susceptible. The onset in the second, sympathizing eye is usually between 4 and 8 weeks after the initial injury to the first eye. However, it can occur much earlier, reportedly as soon as 9 days, or be delayed for many months or even years. But the vast majority, maybe 80%, occur within the first 3 months post-injury.
The exact cause is still listed as unknown, but the leading theory involves the immune system.
That's correct. It's widely believed to be an autoimmune disease, specifically a T-cell mediated delayed hypersensitivity reaction. The hypothesis is that antigens from the injured eye's uveal tissue, perhaps uveal pigment itself, are exposed to the immune system in a way that causes sensitization. The immune system then mistakenly recognizes similar antigens in the uveal tissue of the uninjured eye as foreign and mounts an inflammatory attack against it.
And pathologically, the inflammation looks the same in both eyes.
Yes, that's a key feature. Microscopic examination reveals the same characteristic granulomatous inflammation in both the originally injured, exciting eye and the subsequently inflamed, sympathizing eye. Early on, you see nodular collections of lymphocytes and plasma cells scattered throughout the uveal tract, iris, ciliary body, choroid. A characteristic feature is the proliferation of retinal pigment epithelial cells, sometimes forming distinct clumps called Dahlen-Furch nodules, often located between the RPE and Bruchus membrane. There's also infiltration of the uvea by epithelioid cells and sometimes giant cells. Later stages show a more diffuse, widespread inflammatory infiltrate. The overall picture can resemble uveal tuberculosis microscopically, but crucially, there's no caseation, cheesy necrosis, as seen in TB.
What are the clinical signs and symptoms? How does it present?
In the initially injured, exciting eye, a key feature is often persistent, low-grade iridocyclitis. It just doesn't quieten down completely after the injury repair. It stays subtly injected, may be watery, and tender to touch. You need to look closely for signs like chorotic precipitates, KP's inflammatory cells, stuck on the back surface of the cornea. In cases with a very delayed onset, the exciting eye might have been seemingly quiet for years, perhaps even shrunken if visible, but often some irritation or inflammation flares up again around the time the sympathizing eye becomes involved. Then, in the previously healthy sympathizing eye, the onset can be insidious. There might be vague prodromal symptoms like light sensitivity or intermittent blurred vision. The very first objective sign might be the appearance of fine KPs on the corneal endothelium, or seeing inflammatory cells and flare, protein leakage, in the fluid behind the lens, retrolenticular space, signs an ophthalmologist would look for specifically if anticipating the possibility. As it progresses, the patient notices more definite symptoms like watering, redness, pain or tenderness, and blurred vision. Examination reveals KPs, cells, and flare in the anterior chamber, often vitreous opacities, cells in the vitreous gel, and sometimes swelling of the optic disc, papillitis.
And when it's fully developed?
You see the signs and symptoms of a full-blown, severe granulomatous uveitis, although the severity can vary. The prognosis is always considered doubtful once established. It's particularly grave if there's extensive plastic exudate, thick, sticky, inflammatory material in the anterior chamber, often leading to the pupil becoming stuck down, posterior synechia. Cases with less exudate, a deeper anterior chamber, and predominantly KPs might have a slightly better outlook initially, but they can still worsen significantly. Vitritis, inflammation in the vitreous, is common. Characteristic yellowish-white lesions may appear in the peripheral fundus, thought to represent Dehlen-Fuchs's nodules. Figure 28.1 has C, shows these. Papillitis, figure 28.1 is also common. It typically runs a very long, chronic course, often smoldering for 2 years or more, with periods of flare-ups and remission. Figure 28.17 nicely illustrates the potential severity and the response to treatment in one case.
Treatment sounds like it requires extremely careful judgment, especially regarding the injured eye.
Absolutely. There's the prophylactic aspect first. After any significant penetrating injury, especially one involving the uvea or lens, meticulous surgical repair aiming to avoid any tissue incarceration in the wound is crucial. Some might advocate for prophylactic use of topical or even systemic steroids for a period after such injuries, although the evidence for this is debated. If the injured eye quiets down well and stays quiet, sympathetic ophthalmitis is unlikely to develop. The most definitive prophylactic measure, however, is enucleation surgical removal of the severely injured eye if it has no useful visual potential. This should ideally be done within about 2 weeks of the injury to be maximally effective in preventing sympathetic ophthalmitis. Importantly, though, there's no evidence that removing the injured eye after sympathetic ophthalmitis has already started in the second eye provides any benefit, so a potentially seeing injured eye is generally not removed once the condition is established.
And managing the established disease once it appears in the sympathizing eye.
You treat it essentially as a very severe bilateral granulomatous uveitis, but the cornerstone of therapy is aggressive use of corticosteroids. They can be dramatically effective, especially if started very early in the course of the inflammation. At the earliest sign, treatment is typically initiated with high systemic doses, often starting with intravenous pulses of methylprednisolone, followed by high-dose oral prednisone, for example, 1 mg day, which is then tapered extremely slowly over many months or even years.
Alongside topical treatment.
Yes, this systemic therapy is supplemented with frequent, potent topical steroid drops, like dexamethasone or prednisolone acetate, and cycloplegic drops, like atropine, to dilate the pupil and prevent synechiae. The oral prednisone dose often needs to be maintained at a low level, for example, 15-20 mg daily or alternate days, for a very long time, many months, sometimes years, to prevent relapse, requiring careful monitoring for steroid side effects.
So steroids really have changed the outlook.
Profoundly, yes. Before steroids, sympathetic ophthalmitis often led to bilateral blindness. Now, if treatment is started early and maintained appropriately, the visual prognosis is much better. However, if the inflammation is already well established with heavy infiltrate and structural damage by the time treatment begins, the outlook remains much less hopeful.
What if steroids aren't enough, or the side effects are too severe?
For cases resistant to steroids, or where long-term steroid toxicity is a major concern, other immunosuppressive therapies are necessary. Agents like cyclosporine A, which specifically targets T cells, azathioprine, methotrexate, or mycophenolate mofetil might be used, often in combination with lower doses of steroids. The text specifically mentions oral cyclosporine A as being a useful adjunct, as demonstrated in the case shown in figure 28.117C. Managing sympathetic ophthalmitis requires long-term expert care.
Okay, wow. We have covered an immense amount of detail here, really diving deep into the mechanisms and management. Let's try and bring the key threads together.
We really have navigated a complex landscape, haven't we? From the immediate devastation of chemical burns to the intricate classifications and varied consequences of mechanical trauma. As the textbook summary rightly emphasizes, the eye's structures are so delicate that even trauma that might seem minor elsewhere can have utterly devastating consequences for vision.
Key take-home message for chemical burns.
Yeah.
Immediate, non-stop, copious irrigation. And that's the absolute first step. Then shield the eye and get expert help urgently.
Absolutely. For mechanical injuries, that fundamental distinction is crucial. Closed globe, where the outer coat is intact, versus open globe, where there's a full thickness defect. Closed injuries, the contusions and concussions from blunt force, transmit energy throughout the eye, causing widespread coup and contra-coup damage to multiple structures, often with delayed consequences like glaucoma or cataract.
And for any open globe trauma, a penetration or rupture, the primary therapy priorities are that tetanus booster if needed, immediate IV antibiotics to prevent infection, no topical medications before surgical assessment, shield the eye properly, and urgent referral.
Precisely. And we delved into the complexities of retained intraocular foreign bodies, the mechanical damage, the infection risk, and those specific toxic reactions like siderosis from iron and chalcosis from copper. And finally, we touched on sympathetic ophthalmitis, that rare but sight-threatening delayed autoimmune attack on the sound eye after a penetrating injury to the first, particularly linked to uveal tissue trapped in the wound. Prompt recognition and early, aggressive, long-term systemic steroid therapy are the keys to management there.
Which brings us right back to that point the text makes so forcefully at the very end of this detailed section.
Prevention, it simply cannot be overstressed. Through good public health education, enforcing safety standards, and ensuring the use of appropriate, effective protective eyewear in hazardous occupations or activities, so many of these truly life-altering injuries are entirely preventable.
Reflecting on this whole deep dive, from understanding the precise chemistry of how an alkali literally turns cell membranes to soap within seconds, allowing it to drive deep into the tissues, to tracing the physical cascade of force waves from a blunt impact causing damage far from the initial contact point, to grappling with the complex delayed immunological storm of sympathetic ophthalmitis triggered by an old wound. It really highlights how incredibly specific the eye's vulnerabilities and its responses to injury are.
It truly does. It reveals the eye as this marvel of intricate biological engineering, yet simultaneously profoundly fragile. And the depth of knowledge required to effectively manage these conditions isn't just about recognizing the damage, it's about fundamentally understanding the exact mechanisms at play, how those force waves propagate, how different chemicals interact at a cellular and molecular level, the complex, sometimes counterintuitive dance of the immune system in response to trauma. You really start to appreciate why ophthalmology demands such an intricate, detailed level of understanding.
It leaves you with a thought, doesn't it? How does this incredibly delicate biological system, with its perfectly clear media, its highly specialized cell populations like photoreceptors and endothelial cells, its precisely maintained fluid-filled chambers, how does it manage to function so exquisitely most of the time, given its susceptibility to these very specific, often devastating injury mechanisms? And yet, despite that fragility, how is it sometimes capable of mounting remarkable, albeit complex and sometimes delayed, healing or reactive processes? It's a powerful reminder of the exquisite, precarious balance required to maintain vision and the sheer level of sophisticated knowledge needed to protect and restore it.
A fascinating balance indeed. Definitely something to keep exploring.
That's all for this deep dive.